I'm Elon, medical orthotist and prosthetist. A compression garment is an orthotic device and when correctly prescribed is vital post-mastectomy. Post-surgery swelling can affect the breast, the chest wall, the shoulders, or even the arms, and when correctly fitted, compression garments have proven beneficial in alleviating these post-surgical symptoms. One of the great benefits of compression garments is the reduction of inflammation due to the increase in blood circulation and the drainage of lymph. Other reported benefits include reduced cramping and reduced nerve and temperature sensitivity. The three most important factors of compression garments is firstly, the correct measurements and fitting, and then also patient compliance and education by following the instructions from your doctor and therapist. Thirdly is to ensure that the arm sleeve is correctly fitted and make use of the suspension system often found on the opposite arm to prevent these garments from slipping or rolling down. Always follow the care labels to ensure longevity of the product. Should you find that the product has lost its elasticity or structural integrity, you may need to assess for a replacement. I hope that the information provided is beneficial to the entire team working towards a successful outcome for the patient. So enjoy using these garments because it is performing a valuable medical function. Thank you. Hi everyone, I am Elwan Keane, a medical orthotist and prosthetist. A compression garment is an orthotic device and when correctly prescribed is vital post-mastectomy. Post-surgery swelling can affect the breast, the chest wall, the shoulders, or even the arms, and when correctly fitted, compression garments have proven beneficial when alleviating these post-surgical symptoms. One of the great benefits of compression garments is the reduction of inflammation due to the increase in blood circulation and the drainage of lymph. Other reported benefits include reduced cramping and reduced nerve and temperature sensitivity. The three most important factors of compression garments is firstly, the correct measurements and fitting, and then also patient compliance and education by following the instructions from your doctor and therapist. Thirdly is to ensure that the arm sleeve is correctly fitted and make use of the suspension system often found on the opposite arm to prevent these garments from slipping or rolling down. Always follow the care lanes to ensure longevity of the product. Should you find that the product has lost its elasticity or structural integrity, you may need to assess for a replacement. I hope that the information provided is beneficial to the entire team working towards a successful outcome for the patient. So enjoy using these garments because it is performing a valuable medical function. Thank you.
Good evening. Good evening, everybody. Sheepdale Training Academy extends a warm welcome to each of you on this bright Wednesday evening. I am Meena Mistry. I've been thankful and delighted to see an overwhelming numbers of attendees tonight. We are grateful to Innovative Medical for their sponsorship. There's a live broadcast on the Sheepdale Training Academy YouTube page if you want to share it. As we commemorate Women Month, I would like to introduce Dr. Pranitha Pillai, a remarkable woman in the field of medicine, particularly in oncology and with 25 years of medical experience. Dr. Pranitha Pillai has worked for Doctors Without Borders over a decade. She's an infectious disease specialist as well as a specialist oncologist. She treats a wide range of cancers using state-of-art modern therapies. In addition, she has a dedicated service for young adults with cancer. Thank you, Pranitha, for sharing your time today. So sit back, relax, grab a snack and a drink, and enjoy this webinar. The question and answer session will be after the webinar. Thank you.
Great. Good evening, everybody. Thank you for joining me. Today, we're going to discuss young women, and the question is why? One, well, they're just simply not somebody who was diagnosed at a young age. They're not just a patient with breast cancer. And in fact, what we've learned is that they have rather unique biological characteristics. And it's a unique group. A 20-year-old who's just starting to take risks, make friendships, smoke, drink, go to parties is not the same as a 40-year-old who might have children, trying to pay the bond. And the truth is that their options and quality of life concerns are really different. So what is the reality in South Africa is that 1 in 10, so 10% of patients who were diagnosed with breast cancer in 2017 were under the age of 40. And this is starkly different to the profile distribution in the US, where they say it's usually around 5% of all patients are under 40. Interestingly, in the Middle East and on the continent in Africa, it's around 20%. And one of the reasons they suspect actually a younger population, and there isn't routine breast cancer screening. So in South Africa, what you can see is that, not unexpectedly, is that in the under 40 age group, breast and cervical cancer compete. What is interesting is from some studies in South Africa that we've learned the age at breast cancer diagnosis was associated with your HIV status. But this makes sense, and seeing it's in keeping with the age distribution of HIV in South Africa. But what's important here, I think, is that it highlights that when you see a patient with breast cancer, you need to test them for HIV. In South Africa at the moment, there is no evidence or data that suggests there's any other associations with HIV and breast cancer. So not an increased incidence, and neither is there any change in your survival. Now, perhaps today, one of the most fascinating things about breast cancer is the molecular biology of it. And on any given day, you're likely to receive news of something new that's been discovered. Essentially, though, the main thing is we use 4 main molecular subtypes, and that's based on the receptors on breast cancer cells. So either these hormone receptors, estrogen and progesterone receptors, and they're part of the luminal breast cancer diseases. And that essentially means that it's a receptor for estrogen, which sends signals and for those breast cancer cells to grow. And we also have what's called HER2, which has HER2 receptors, and then basal, which is triple negative. So essentially none of the receptors. So the main point here is that when young adults with young women with breast cancer started to become quite noticeable, in the US, what was peculiar was that there was a more aggressive pathology, which was the triple negative and HER2 disease that was predominant. In West Africa, interestingly, it's actually triple negative. But more interesting is that in our South African population under 40, it's predominantly estrogen receptor positive. So it's very, very different from our older population, and definitely different from what we see in the literature about those patients beyond. Just in terms of this graph, the one at the bottom is just showing the age distribution of all adults in South Africa. And on top, this is related to, so you can see in blue, the Black population in America, and green is the white population in America, and the red relates to Black South Africans, which have a very different biological profile additionally. So the question, though, became, well, why do we see this with young adults in South Africa? And one of the interesting concepts is that over time, the birth cohort effects would have changed. And so we see that there's been a decrease in the amount of births per women from 1940 to the 70s, much more use of oral contraceptives, widespread use. And when you see, this might make a bit of sense about age of menarche has declined, and that patients who've had the highest parity. So in South Africa, the 3 provinces which have the highest parity have the highest estrogen receptor negative breast cancer patients. And essentially what that means is that it's about the lifetime exposure to estrogen. So if you haven't had as many children and interruptions to your estrogen, that would then be more a risk factor for your estrogen receptor positive cases. what is also important is we've learned that estrogen receptor breast cancers generally have a better prognosis. In South Africa, scarily enough, more than 50% of the population, but this is all ages, present with more advanced disease, stage 3 and stage 4 disease. In young adults, though, we just don't have data about whether that's actually true. So that remains to be seen. And of course, that brings us on to the question about screening. I want to make the point that we know screening reduces mortality, and quite significantly, 30 to 40%. And generally, the discourse around screening is about your pros and cons in the younger age group, about unnecessary invasive techniques or doing any, whether that actually has a survival benefit. And so in that 40 to 50 year age group, there generally tends to be, well, should we screen, shouldn't we screen? And so you should have a discussion with your patient. However, you can see on the top pie chart in South Africa, a third of women with breast cancer are under the age of 50, which means that we have good enough evidence that for general screening for under the age, so the 40 to 50 year age group, we have pretty good data to do that. Now, I want to make the point that the language that we use about mammograms, and so it's related to the usual controversy about whether we should do screening in younger populations. But what's important is that it's for the average risk patient when we talk about this. Whereas in under 40-year-olds, what we notice is that majority of young women are actually finding the disease, the lump themselves. So they present themselves with the abnormality. And so we have to talk a little bit about understanding mammogram and screening in a younger age group. So mammogram in this very high risk age group is related to a diagnostic capability. So what we know is that you can't really say a patient is too young unless you know what their actual risk is. And we'll talk a little bit about that later. So the issue generally with young women is the breast tissue density. And so with mammogram, you aren't able to see these lesions. So there are guidelines for MRI screening. And the risk usually is for somebody who has a lifetime risk of more than 20 to 25% of developing a breast cancer, those with BRCA1 and 2 mutations. If they do have the mutations, only once they're over 25 years old would you do an annual mammogram, and the MRI then becomes staggered. If you've had prior chest radiotherapy, you would only do it 10 years after that radiotherapy, considering the long lag time before you could develop a cancer from that. Interestingly, in the US now, they are making it mandatory that when you see a mammogram, which would be important for many of the participants today, is that you might get a patient who brings their mammogram result back. And that if you have to say whether I actually should consider rather sending this patient for an MRI, is that we should really be talking about knowing what their breast density is. And that includes, in fact, in older women, because since, we're not all alike. So in terms of diagnosis, the problem is that young adults do generally present later. They detect it later in the course of the disease. They might delay seeking help. Doctors generally seem to be less familiar with the risk of cancer. As I said, one of the misconceptions, which is about you're just too young to get cancer. And symptoms have been found in some studies that they generally dismissed as fatigue, stress, persistent hangovers, and adolescents, young adults just generally won't feel taken seriously. In 2010 UK survey, a quarter of young adults had 4 GP visits before they were diagnosed, and a third of those patients were diagnosed in the emergency room, which essentially, again, we're saying if this young adult is finding it, then we have failed a little bit in our diagnostic capacity. I want to make the point about biopsies. So for many clinicians listening today, you might find somebody who presents to you in your consulting room with a lymph node under the axilla, and you might take an FNA. And this becomes, for me, in my experience, one of the rate limiting steps that we found. You might take an FNA, which would be wholly inadequate, so you wouldn't be able to make the diagnosis. And in general, the biopsies that would be done on a breast mass, for example, would need to be of a particular quality and type. And so you can do stereotactic or these ultrasound-guided core biopsies. The clip placement is what is critical. And for you to know, for your patients in general, right? Because what we know with young adults is that we want to conserve their breasts. And so if they had a lump during the biopsy, if those clips are not based, we give chemotherapy and we get a complete response. At the time, for the surgeon who now needs to go in and take it out, doesn't know where it was. So we aren't able to actually get good oncological surgical outcomes. And for radiation, especially for younger women, which is very important, is we give a boost of radiation to that lumpectomy cavity. So if there are no clips, it makes a big, big difference. I'm quite passionate about this because of my experience in rural, working in rural South Africa, and a lot of the referrals that we get to the tertiary centers this is where our patients tend to fail within the system because it affects everything thereafter. So we're talking about a young adult. So essentially we're talking about hereditary risks. And what is the link? So we are all aware about mutations in the BRCA1 and BRCA2 genes. And for those who have those mutations, the lifetime risk is around 60% compared to 12.5% if you say for a general population. I've given a table which talks about the risks, but for ovarian cancer or prostate, for example, with the BRCA2 mutation. And usually when we do see BRCA mutations, they tend to be younger patients, which means they tend to have what I would say a disfiguring narrative. They tend to have bilateral mastectomies, risk-reducing bilateral salpingo-oophorectomies, and essentially what happens, a worse anxiety, worse body image, in fact, worse sexual health because your entire body changes. Patients get missed, usually young ones, for gynae surveillance because they might be on tamoxifen, which is a selective estrogen receptor modulator drug. So that could end up with, they end up with endometrial thickening as a side effect. Or we just don't check the estradiol, whether they are actually postmenopausal or not. What is important is that there's actually no convincing data that bilateral mastectomies have any overall survival benefit. However, there is a very, very specific high-risk patient where that should be discussed. But I think we need to make sure that any discussions along these significant disfiguring and invasive procedures are discussed at a MDT. And, you know, we should be unbiased when we have those discussions with our patients. So when it comes to genetic counseling, now this table, and as I said to you, what's fascinating about breast cancer today is that on any given day, we are learning about a new gene mutation. And so beyond BRCA, this tells you how much different associated cancers will be for you as clinicians, for family members, a risk for a young adult. So we would normally consider doing genetic counseling and testing if you have a family member with a known BRCA mutation, there's anybody as a young adult under 50 with a breast or ovarian cancer, if you have one relative who is young. But the point about 2+ relatives with many cancers is what's related to here in this table. And so prostate, which is related now, many prostate Men with prostate cancer have a BRCA mutation, thyroid, rectal, pancreas, ovary. So it's no longer having a suspicion in your mind about only those with breast and ovarian cancer. And this, I think, is what has fundamentally changed the way we practice medicine today. Ashkenazi Jews tend to have a higher risk of breast cancers. And from what I understand, in South Africa, the majority of South African Jews do have lineage from there, and male breast cancer. So we want to talk about risk reduction. You might see in the literature something about chemo prevention. So the first thing I want to make a point is about, can you really be truly say that we can prevent something? And so the idea is to rather talk around risk reduction. And so one of the topics today is, if you have this young adult who has such a high risk of developing a breast cancer in their lifetime, can we give something? Chemo prevention, it's called usually. And that's usually with a drug like tamoxifen or a aromatase inhibitor, which block the estrogen receptors. So we have some evidence that it decreases the incidence, so new breast cancers, but there's a bit of suspicion it might be due to the high rates of mammographies and overdiagnosis. And essentially, we might be actually overestimating any benefit, and the harms might be underappreciated. There's lots of studies which show compliance, especially with young adults, to take a tablet without clear, obvious benefit and many side effects, that the compliance is usually less than 60% for most young adults in the studies that have shown. I think what is difficult here is that you have a healthy patient and you need to convince them to take a potentially harmful preventative medication with side effects. So one, it places a lot of burden on the clinicians about being able to do that, on the patient to accept those risks. And the truth is, as a patient, you might be, well, I don't want to get it. So you're caught in a difficult place. I think what's important is that there's no single cutoff for what that risk is for us to say this patient should now go on taking a medication like tamoxifen to prevent their risk of getting it. The other thing is that there are many, I've put a few references to these models. They are extremely complicated and confusing, even for me. Some have very few factors, some have many that you would input, but I think it's still useful to use to get a sense of who's this very high risk patient that might actually benefit. So in terms of pregnancy, that would make sense, right? One, it's the most common form of cancer that are found in patients who are pregnant or who have recently given birth. But I think, in my experience, for young adults who have been diagnosed when they're pregnant, it must truly be the most difficult decision to have to make. But for what we do as oncologists, our treatments are generally based on the stage, the treatments, for example, some chemotherapies, which trimester we might be able to give them in, and patient preference. But I can tell you now, it is one of the most painful discussions to ever have. So for young adults, fertility choices are important. So before treatment, there's many strategies that we do to limit the damage to the ovaries. So just before chemotherapy, for example, to ensure that after treatment, the patient is able to have some preserved function. And also we know about egg freezing, embryo freezing. Just last week, in fact, there was some data that came out showing that none of these treatments actually affect your chance of recurrence of the cancer or of developing a cancer. And for most young women, that's important. It's an important thing that they do ask about. So in terms of fertility after treatment, I think, one of the things is that we do induce this early onset menopause, whether it's chemotherapy, hormonal treatments, and it affects patients' quality of lives. And so in reality, you have this double-edged sword that a young woman finds herself in. You are saying to her, you have, for example, a hormone receptor breast cancer, that with these hormones in your body, estrogen, progesterone, the risk is that it's going to stimulate this and it could recur. So we need to prevent you having estrogen. And so we put you in a menopausal state. And nobody wants their cancer to recur. However, they also want to have a family and they want to have children. And so it puts this young woman in a very, very difficult position. And this brings me to essentially the main issue today, which is what's so unique about young adults. Disclosure is difficult. Social exclusion, dealing with friendships, being told, maybe being invited to a party and you're saying, you're having chemotherapy, or you just don't feel like it, you feel terrible. Disclosure has been an interesting thing for a lot of my patients as well, because one of the issues is that it might ultimately define who they are. Child rearing, I think there could not be anything more overwhelming than having to raise children, either while taking treatment or just dealing with cancer in totality. In fact, one of my patients was diagnosed when she was pregnant with a lymphoma, and she said to me in the beginning, her main concern was just whether she was going to be alive to see her child. And now, all these years later, in remission, she said she's in a custody battle. And can you imagine today, she's worried about whether she's going to see her child again. And it just gives you a spectrum, an idea of where this young adult is going to be throughout their course. Workplace issues. I mean, that's a reality. Again, you might be found that you constantly being defined as being the person who has cancer. One of my patients had said that walked into the office and someone said, "Oh, you lost so much weight." And so there tends to be lots of issues around that, sick leave, etc. But sexuality and body image is extremely difficult, especially with this disfiguring narrative around surgery, intimacy issues, dating, all the weight gain, hair loss, all of these things come together. But essentially that sexuality is an experience on so many levels, much more complex. And I think we probably don't do justice to our patients in seeing them in that way. And what is particularly important today is that we're just seeing so many young patients being diagnosed, but being treated, who then transition into this later adulthood life. And that comes with its own set of challenges. In terms of cancer never really being over, something I'm terribly passionate about, and from my experience working with young adults, is that there's a lot of pressure to fight, to survive. There's a lot of terminology that's related to being survivors, which essentially says that you've got to get through this. And if you don't, that you just didn't fight hard enough. Or those patients who have metastatic disease, who are not going to be a survivor. The truth is they survive every day. And again, we do a great, injustice to young adults when we talk to them in a way that's not about their reality. For me, I think strength is exhausting, and telling a young adult that you have to be resilient, or making them feel bad that they're not resilient enough, not grown up enough, because they aren't taking this. Even though we do understand a lot of the support comes from saying, yes, I can do this, I can do this. The reality is just knowing that on every given day, that's not going to be the right thing to say. I think the last year, if I had one take-home message this from this presentation, would be that each and every one of you tonight listening have an intimate sense of what that social isolation is. And that's a glimpse into what a young adult with cancer experiences. It's a particular feeling that you can't necessarily describe unless you've been through it. And so for young adults, I want to spend some time on this because especially for many of us clinicians, maybe to families, we constantly talk about living healthy lifestyles, modifying things that we can, and weight is one of them. However, clinically, there's only some evidence on a survival benefit for estrogen receptor positive breast cancers, which means that there might be patients who have, for example, a triple negative, where they won't see a survival benefit from losing weight. However, there's always benefits to losing weight. One, in terms of tolerating treatment. We know that there are some outcomes of patients who haven't lost weight, for example, or might be too obese, maybe too big to be able to get onto a radiotherapy bed. And so they are important aspects of it. However, it's not a risk factor to get breast cancer. And it is a risk factor because our patients live longer, so they could end up with, diabetes, hypertension, cholesterol, etc. But we know that our patients are gaining weight from all our treatments. And it can only be a modifiable thing if it's related to your life expectancy and your actual biology risk of recurrence. So a patient who's 40 with metastatic breast cancer, whose life expectancy is much limited, or a 20-year-old who had radiation when she was much younger, those are two different patients that we might be talking to. So again, it's just about that there's no optimal prescription. None of us, I can tell you today, would be able to say, do this, 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 and you would lose your weight. But we want to encourage women to keep their BMI less than 25. And the main thing this comes back to is what I was saying about what I'm passionate about is how we talk to young adults. Is that we can make them feel guilty that they weren't controlling their weight. I had a bunny child this weekend, so it's going to be very impossible for any person on any given day to be just good at it, right? And so the main thing for me, though, here is about guilt. A lot of the patients, young adults who I have treated, is the overwhelming thing is guilt. The day they are diagnosed, what did I do? What did I do wrong? And so if by any chance we can avoid and be mindful of not perpetuating any more guilt on somebody who's, having a tough time as it is particularly important, I think, that we must remember. Now, this slide is deliberately busy. Deliberately busy. It's to give you a sense about the actual financial toxicity side effects that Now, for a young adult, you're talking about somebody perhaps who doesn't have a job, maybe hasn't finished, isn't having paid off the bond, has school fees, for example, or university fees. These are just approximate costs, but if you go through everything, a mammogram, ultrasound, all your scans, the biopsy, having a genetic test, particularly if you're younger, or, it can make a big difference. The oncotype is one type of genetic test, which could make a big difference to a young person if they could avert getting chemotherapy. Surgery, hormone treatments, Herceptin, which is a drug we use that blocks the HER2 receptor, and has fundamentally changed the prognosis for those patients, which is an aggressive subtype. And as many of you know, in South Africa has been a battle and is only now just recently been available in the public sector, is still about 20,000 a shot, and you need 19 of them. So it can get, and this is beyond the new immunotherapies that we're talking about. Radiation therapy, a whole treatment could cost up to 100,000. And then you have side effects, which add to the cost. So your hospitalization, all your drugs. The patients who also have side effects of treatments tend to have to be in hospital and spend much more money, almost 2 times more than patients who don't have side effects. Transport, time of work, and wigs and bras. We just heard from the sponsor, but these are big things that are out-of-pocket costs that we don't always take into account. So I just want to conclude with, despite the common misconception that young women, young adults don't get cancer, they do. And I think the problem is today we're sitting with, there's no one screening tool. There's no one perfect diagnostic tool. There's no one perfect treatment. And that it's really no one size fits all. And so today I would leave you with, if we could just be aware, be alert, and be mindful to a young adult with cancer. Thank you so much for listening. I look forward to taking your questions. Thank you again.
Good evening, everyone. We'd just like to thank Dr. Pranita for a wonderful discussion. We are now at our Q&A session. So please feel free to type your question into the chat box, which Pranita will then answer for us. Should you wish to ask a question personally, you can raise your hand in the chat box or ask to be unmuted. You can then ask us the questions and Doctor will then try and answer that. Please note, I'm also going to be putting in a feedback form link into the chat box. It is essential that each of you actually complete the feedback form. It will assist us in sending you your digital certificates, because there are a number of us that actually sign on and it's not the same, the name is not the same as on the registration list. So this way we can identify you if you've completed a feedback form. For all those watching on YouTube, you are also please asked to complete the feedback form, because it's really essential for us to send you certificates as well. So I'm going to now open the floor and get everybody to start asking questions. The first question did come in while the doctor was chatting. So doctor, a question from Shelley. Please expand on the link association between breast cancer and HIV.
Oh, I'm unmuted. Great. So what we have is that convincingly, and this is beyond even just South Africa and the US, that there is no data to suggest any link between HIV and increased risk of breast cancer, a change in your mortality or survival, and that in South Africa, the study showed, there's been a few, I think the one was at Barra and there was another one in KZN. And the link there was our population profile of HIV, this younger population. And so you have cervical cancer and breast cancer, this competition where a lot of young adults who are going to have HIV are going to develop breast cancer. And that's why you see this age at breast cancer diagnosis association, but the link is not that it increases your chance of getting it. The other important thing I would say is that when there's important considerations for treatment, so, giving chemotherapy for low CD4 counts, that we might omit certain drugs. And and then just the welfare of the patient. Because if the patient is not virally suppressed and is not doing well, it could affect the outcome of their ability to recover their white blood cell counts, their nutrition, wound care, particularly for advanced. I think one of the saddest things that you can experience, and I'm sure a lot of my oncologist colleagues online would agree, is seeing this young adult who comes in with this inflammatory breast cancer, large, that is just oozing. And so they generally, even if they had surgery, if they're low CD4 counts, they might not do well for wound healing. But I think that it is at least reassuring that they don't have any increased risk or it affects their survival. Let's see what other questions here.
Okay, Pranita, can I read out the other questions to you? Or?
Yes, please.
Okay, so we've got quite a number of questions that have come in, as well as some one that has been typed in from YouTube. So the next one that we need to was by Dr. Buthelezi. He's asking to expand on breast cancer and pregnancy, considering the effect on pregnancy. So I'm not sure what else you would like to say there.
So considering the effects on the pregnancy. Okay, so this is a topic on its own. And a gynae oncologist would tell you that this is changing every given day as well. So in terms of the effect on the pregnancy, so the main thing is, usually it's the patient, the tumor, and your treatment. And so when you look at the patient who's pregnant, what is the risk factors, for example, before, the type of tumor, and when was it diagnosed? So the trimester usually is the one that helps to direct almost anything we might consider about the patient's effect on this pregnancy, the tumor effect on this pregnancy, and any treatment we might do that would affect the pregnancy. And so for first trimester, second trimester, third trimester, it's all about this timing and which treatment to do. So an easy one is that we would not do radiation during and delay that. But for chemotherapy and surgery, a lot of it is about the timing. So in the first trimester, we wouldn't give chemotherapy due to the teratogenic effects. And usually around the second trimester, it's just about getting them to the third. But today, I must say, we have good drugs that are able to be tolerated without crossing the placenta. And it's getting them to time. It's about the timing to get them to surgery. But it depends on the stage. And it depends on the patient's preference. TOP is still also not a given anymore, but also there are patients who do. They have, lives outside that pregnancy, and so they make that. In terms of the physiological changes with the breast cancer and pregnancy, there is, if I recall, some stuff about the signaling, because as I mentioned, for some cancers, with the progesterone receptor and the amount of progesterone, you can have an increase of those signals that would increase the growth of the cancer. But it's, again, the data is not that it would be, yes, it definitely sort of increases the growth of the cancer at that time. But I think then that's where the biology of the tumor might become important, and then age. I'm trying to think if there's anything else in terms of pregnancy. There's for anyone who's interested, the European Society of Medical Oncology this week just released, so it's called ESMO. They've just released a new guideline on breast cancer and pregnancy, but I didn't go into it because it's a lot. But it's but it's very helpful to say that it's definitely on the table for treating it much more aggressively. Okay.
Okay, next question. Local estrogen for vaginal atrophy and thinning on those on tamoxifen indicated or contradicted. Does it promote cancer?
Okay. That's a great question because it seems sort of intuitive that it would. And we have today convincing evidence that it does not. The amount of estrogen, firstly, that is in those preparations is extremely low. Two, the systemic absorption of that estrogen is not at all within any amounts that would cause cancer at all. So the local estrogen therapy is not a problem, and this I know from all the gynae oncologists that I've been trained under, that we shouldn't be not treating the vaginal side effects, particularly if a patient has, for example, cervical cancer and had radiation or the sort of effects from treatment. So for me, it's definitely not contraindicated. And there are also lots of different preparations. So it's not a once-off. There are different concentrations that we could consider.
Okay, so then there's one more. Do you consider age below 35 being a risk factor? I'm not sure what or how, it's from Dr. Zpack, and it's just saying, do you consider age below 35 being a risk factor?
No, I think I would be, it would be out of my remit to make such a definitive statement that I consider it being a risk factor. No, I'm not sure. I don't think I could say that, yes, it's a risk factor. I think, in fact, a lot of the research I've done is related to why in Africa we are seeing such a different profile of young adults with breast cancer. And so one of the issues is, yes, we've learned a bit about the biological peculiarities about it. For example, in West Africa, we're learning a lot more about young adults and the type of biologies that they get. So is it being young that's the risk factor, or is it related to your estrogen exposure? Is it related to a also because, you know, the problem with risk factor studies is you have the lag time bias in any studies that we find when we look at the research, that it's very hard to know whether, unlike smoking, which there's convincing evidence that is a risk factor for lung cancer, that lag time bias in any data that we might get makes it very difficult. So my takeaway from that would be, no, I'm not willing to say just being under 35 is a risk factor. I think we need a lot more. And because it's so complicated, I suspect it's going to be many more things than just being age. And lastly is just to say that for me from today, which is understanding a risk in the young patient. So in a patient, you know, under 40, it's about that person's risk, not the age being a risk factor. And so for me, that being aware and being alert is to find the patient with the risk and treating them differently. I think that's how I would answer that question.
Okay, then the last question I have here, and I'm not sure if that was sort of already covered in question 1, but it says the effect of pregnancy. Oops, somebody else just asked the question. I'll do that one now. Effect of pregnancy on clinical diagnosis, palpitation, etc., modalities of diagnosis.
So a little bit like what I went through, it's one of the most common cancers that are diagnosed during pregnancy. Why? Probably because that's the time the patient sees the gynecologist and actually has their breast examined. I think that during pregnancy, the breast changes so much that those lesions can become very, very difficult to palpate. And then, of course, it's the issue around the exposure to radiation, doing unnecessary scans, and so you risk that's how these patients can get lost. Yet at the same time, it is the most common cancer diagnosed. And so it does make it very difficult in terms of our diagnosis. But the fact that because they're pregnant, they get a much more intensive care package by their gynecologist. And there's a very, very strong possibility as well that the clinical diagnosis then is also brought by the patient because they become acutely aware of the changes in their breast. So I'm just going to say to anybody who I have not answered adequately, which is very frustrating when you're on these webinars. So you must please don't hesitate to put another question or let me know if I haven't answered specifically. Rosni, you want to go ahead?
Okay. Some medical aids now say they will only fund a mammogram every 2 years for over 40s. Previously, mammograms were annual. Is this based on new clinical evidence? Is it only financially based? And people should pay for it themselves if the medical aid won't pay. So I'm sure, obviously, you can't talk on behalf of the medical aid, but just in terms of the fact that, is it based on new clinical evidence?
Okay, so the one thing about age and mammogram, what I was saying earlier is that if you're talking about that 40 to 50-year-old age group, which has been contentious and which is what you're relating to here for that average risk patient now. So not this high risk younger adult that we've been talking about, but for that average risk 40 to 50-year-old. The South African guidelines for mammography, which is in the SMJ by Dr. Lipschitz, is about the guidelines. And that's from 2018, but is very, very convincing and very clear that for patients over 40 to 50, that they do get screened. Now, for medical aids, as I said, that's if there's no one, machine, if there's a rage against the machine, I think it might have meant medical aids. But it depends on the medical aids assessment of risk or risk they're willing to take, if I understand. So anything around medical aids that might be made in terms of, it's that whether this medical aid is willing to run the risk of putting out the cost that the patient or that they would end up having to spend on breast cancer. And the other thing I wanted to make the point is evidence can be very easily selectively used. And when we talk about interventions, it's about our appetite of risk. And I think medical aids versus patients versus clinicians, we all have different appetites of what risk we would be willing to take. So that's why I would say that that probably explains a lot why you won't get a simple answer in medical. Each medical aid is different, appetite for risk, depending on what it is. And unfortunately, today, everything's about the type of plan the patient has bought, and which they didn't realize actually was one of the issues. Okay.
Okay, so the next one, if a patient with no signs and symptoms comes into your rooms and you find an incidental enlarged supraclavicular lymph node on examination, would you suggest referring for a mammogram?
So we all know if we found a supraclavicular lymph node as a clinician that you'd probably jump out of your skin. And the problem with the supraclavicular lymph node is that it comes from head and neck. It's going to come from breast. It's going to come from abdomen. It's going to come from pelvis, gynae, cervix, ovarian. And so any supraclavicular lymph node on examination means that if you actually didn't examine, do an ENT, head and neck examination in a patient, particularly today, HIV patients or of pharyngeal cancers, for example, then you would be doing them a disservice by saying, go for a mammogram. And that can sometimes happen where lymph nodes end up, even the axilla, for example, we've seen, which has been metastatic from other places, is that's the risk, is that you only do that. So for a supraclavicular lymph node on examination, it literally is the classic story, full history, full examination, context of who this patient is. And again, is it this high-risk young adult for breast cancer? Is it somebody who you suspected for some reason or the other? Or is it a patient who you've been seeing? Usually for GPs, you see a lot of, ENT blocked nose. And nasopharynx in young adults is particular in South Africa, and they usually present with the level 5 lymph node. So nasopharynx, which drains down, can sometimes present that way. So I wouldn't say that you shouldn't do it at all. I think it's part of a workup based on your full examination. And but just remember, supraclav, head and neck, chest, breast, abdomen, pelvis.
Okay, the next question, how common is malignant phyllodes in young women?
Oy vey. There has to be something I don't know, at least. So that's a good one where I cannot definitively say how common that is. I do not have a number on the top of my head. I'm sure there's somewhere, in there that might be on a hanger there somewhere, but I'm gonna confidently say I cannot give you an answer on that.
Okay, so if there's anyone else that would still like to ask questions, Dr. will be on even after 8 to answer those questions. For all those that do not wish to ask for questions after the session is over, you will be able to leave. We've just got our closure to do before you actually sign out. Sanette, do you want
Roshni,
to move into?
Sorry, Roshni, I just wanted to say one last thing,
Okay.
which is that I actually would like to hear from what people's experiences in their practices or family members, etc. So I actually would look forward to having that feedback from those who are on the webinar. And of course, if you have any questions, you have all my details. Please feel free to call me anytime. Thank you for listening.
I am Elawan Keane, a medical orthotist and prosthetist. A compression garment is an orthotic device and when correctly prescribed is vital post-mastectomy. Post-surgery swelling can affect the breast, the chest wall, the shoulders, or even the arms, and when correctly fitted, compression garments have proven beneficial in alleviating these post-surgical symptoms. One of the great benefits of compression garments is the reduction of inflammation due to the increase in blood circulation and the drainage of lymph. Other reported benefits include reduced cramping and reduced nerve and temperature sensitivity. The three most important factors of compression garments is firstly, the correct measurements and fitting, and then also patient compliance and education by following the instructions from your doctor and therapist. Thirdly is to ensure that the arm sleeve is correctly fitted and make use of the suspension system often found on the opposite arm to prevent these garments from slipping or rolling down. Always follow the care labels to ensure longevity of the product. Should you find that the product has lost its elasticity or structural integrity, you may need to assess for a replacement. I hope that the information provided is beneficial to the entire team working towards a successful outcome for the patient. So enjoy using these garments because it is performing a valuable medical function.